Professor Burci and Professor Legge. You have made my job very easy. So I would like to focus a few points on the implementation of IHR or the uh, uh, efficacy of the instrument, mainly from a developing country perspective. So uh, first important uh, issue is that in the history of IHR from 2005 to 2016, WHO declared public health emergency around 5 times. Out of these 5 times, 3 times it came under criticism. One for acting very hastily, and 2 times for acting very late. So the question many people are saying is that, it should have been much more of a technical uh, decision and should not be a political decision. So my take on this issue is that it's always be a political and technical decision, uh, precisely because of the many of the international political economy as well as the economic implications on such decisions on the people's life. So there, the decision is going to be political and technical. But at the same time, the question is that which should prevail, and how do we sort of balance that these decisions are based on much more technical information and much more based on based on evidence rather than merely a political uh, decision. So here comes the IHR 2005 compared to earlier instruments. It gives much more powers to secretariat, I would say, instead of director general, has much more powers to make such decisions. There are certain changes compared to the last version of the IHR, but here there is enough powers to do that. But then that takes us to the question that why then WHO comes under such criticisms, or why such powers are not being exercised. That takes us to the question that even though this instrument is there, WHO's own institutional weakness prevent WHO from acting as a or acting using its own mandate or its own powers vested on that organization. If you look at WHO's history, uh, only 2 legally binding instruments they have come up. One is a framework convention on tobacco, and secondly on IHR. IHR, of course, was the first instrument. So these were the only 2 legally binding instruments it has come out, and FCTC is under Article I think it's 19, and this is as a regulation. The other one is an international treaty. Why is it so? Interestingly, uh, both more or less came from under same director general who exercised the powers, and also you to note the point that that director general never sought a second term, or it would have been also impossible to get a second term. So there is a WHO always exercised its powers in a very self-restrained manner and seek in a seek the cooperation of the member state most of the time, and it never exercised the powers vested on it. So whenever it exercised, some people had to pay some price for that. But I think that's why there are 2 institutional weakness mainly. The one is that, of course, is the funding, which David already mentioned to you. Much of its funding coming from, even for the emergency program, is through donors. It's not from the assessed contribution. And secondly, um, the director general can currently get 2 terms. So everybody would like to have a 2 terms. I think instead of that, I think it should be maybe instead of 5 years, it should be 7 years, and that's it. So that gives the powers, that gives some kind of confidence to the head of the organization to exercise the powers vested on the institution. So that takes me to the other 2 points related to the exercise of power. One is on the transparency. So people have written already that the how the emergency committee works. Emergency committee is actually nominated by the from a panel suggested by the member states and nominated by the DG. But all these meetings, you will get an outcome document, but you never get the whether on what basis, what were the evidence these emergency committee considered in their meeting to take a decision. And also, we don't get the detailed minutes of the meeting. So there are people have written already about the decisions of about the committee on Ebola, even though they found that it satisfied the criteria to declare it as a public health emergency of international concern, but the committee decided not to go for it. So why this, if it's an objective decision, it should have happened. So why the committee did not decide? In one of the reports, the statement they say that, okay, it will not add any benefit, right? It will not add any benefit. Therefore, so that so I think if the minutes are available in public domain and the evidences are available in public domain, then there would be some kind of we can ensure some kind of objectivity in the decisions, and we can also ensure that the politics is not overpowering the evidence and scientific based decisions. And that also takes us to the question of accountability. So here I would say accountability of member states and accountability of institutions, WHO. Under IHR, all member states are supposed to submit a report regarding IHR implementation to the World Health Assembly. But we will never see those reports, and nobody's in fact submitted. Okay, they just read out whenever there is an IHR agenda, and in 3 minutes nowadays, I think it's a country gets 3 minutes to speak, and within that they have to mention this. Why not there should be a much more of a detailed report submission to the assembly through online. They don't have to read out the whole report, but they can always submit. This is what the human rights bodies do to ensure compliance. So this is an example of non-implementation of accountability framework. Similarly, the WHO, the institution should also make at least an annual report regarding the implementation part of it and the challenges they face, including finance, and also that also ensure kind of transparency in the mechanism. So that is not existing. So having said this, let me move to my second theme. That both speakers already touched upon is the core capacity issues, and the core capacity issue. One of the IHR review committee report says that around 2012 there were only 42 countries which complied with declared that they have the core capability. When it around November 2015, 65 countries declared that they have the core capability. On the same report says that out of 193 state parties, 84 requested and have been granted an additional 2-year extension for the implementation of the deadline. So that is 84 countries. That constitute around 43% of the membership. And 68 parties have submitted a plan for implementation, and 44 have not communicated their intention to WHO. So you add this 84 plus, out of that 84, 68 had a plan, and 44 never communicated. So 84 plus 44 you add. So that will basically give you the number of countries who actually failed to implement this. And that question takes us to the reason for why there is non-compliance with the core implementation. That's exactly I would like to agree with David. The core capability issue is very much linked with economy. And before getting into the detailed discussion about political economy, I don't have any to do that. But most important thing is that you cannot build a core capability only to meet emergency until and unless you don't have a robust health system. The robust health system, you cannot have a core capability only to meet emergencies, right? So that's both speakers said that, and Professor Burci said you cannot have a neoliberal approach to the public health and say shifting the burden to private sector, and private sector will take care of the healthcare sector. This uh, this will not work. As we have seen in India now, as a part of our COVID response, many states have to take over the private hospitals, or even they have asked private hospitals to take the patients from the public hospital who are facing problems with other ailments and so forth, so that they can declare the public sector hospitals as COVID hospitals. So the point is that we need a clear-cut investment in public health and build a robust system, so that will automatically will lessen your burden of building the core capability. So primary, when we talk about always health system, we have in mind is a tertiary care. Not exactly. That's not true. We need a very primary, a robust primary health system. That's the foundation of a robust health system. And here also, I would link this to again to WHO's own on incapability to clearly articulate the need for a public health care system with the investment of the government. So WHO of late started saying, at least 2012, 2013, 2014 and all, when we started discussing about the universal health coverage, the advice from WHO is that it doesn't matter whether it's private or public. What matters is the service. So this kind of either here nor there kind of advice will not help. There should be a clear advice, and many developing countries are depending upon WHO advice. So that take me to the next a few issues. Why the developing countries also use some kind of suspicion with the IHR. One reason is that always that Professor Legge said about the colonial package of the system, and taking it further, what we now call it as a health security approach. The health security approach is an extension of some of the concerns related to the colonial period, and so therefore they think that this may and a complete health system approach will lead to kind of isolation of developing countries. So therefore, they are a bit reluctant. And health security is a very sophisticated word. We use it, but what they also imply by that is the connection of many of these establishments who work on health security's close relation with the military establishment. If you look at much of the core capacity related to infectious diseases existing actually with certain institutions which has close links, or they're part of the military establishment, whether it is in US or in many other countries. So therefore, always the international cooperation or international coordination on these issues are viewed with some degree of suspicion. So then the most important issue is that of the kind of political economy we are in, and the the, to have a coordination system, but people, the kind of political economy we practice, especially the trade, is more of competition and killing the uncompetitive uh, sectors and export as much as and you earn. So if you follow this, or it also translates into the domestic policies, is that uh, as long as you get uh, cheap import, you use that, and you focus where you can export. So you don't have to maintain a national core capacity in the manufacturing. As a result, uh, many countries who do not have manufacturing uh, capabilities in some of these products which are important or uh, critical for the COVID response. So what was the country's response? Even many countries even do not have a capability, the capacity to assess how much is the inventory and production capacity on these areas. So the knee-jerk reaction is export ban, and resulting in disruption of global supply chains uh, and resulting in shortages. So this in a way basically disrupting the any kind of coordination effort. Then who will take the lead? Again, it again falls on the international institutions, WHO definitely, and UN. And in fact, UN General Assembly passed a resolution on 20th of April asking the UN General Secretary to prepare plan along with working along with the WHO and other international agencies to ensure access to these commodities which are currently available and also the future commodities. So, so at the but these agencies are not in a position to act because they have various other constraints. They have institutional weakness for that. So some of the important weakness come from the financial weakness because we do not have a sustainable financing model uh, for the international institution. Lastly, I would say every crisis resulting in setting in one layer of governance, one more layer of governance on the emergency system. So, of course, the IHR sets an IHR committee. It is an institutional mechanism that created as part of the IHR. So, immediately the after the COVID crisis, the Ebola crisis, we have two more layers of mechanisms to uh, evaluate the or guide the emergency response. We have an independent oversight and advisory committee for the WHO's health emergencies. Then we do have a program, emergency program, and then we do have a global preparedness monitoring board. And now what I hear is that one of the draft resolution currently in negotiation in Geneva is proposing another independent review of WHO's response on COVID. So each crisis is adding one more layer of governance. And this is in a way fragmenting the whole governance mechanism related to emergency response. And more actors are coming in. There are earlier there was only WHO, then HIV added the Global Fund, and then the immunization drive added on Gavi. Then the World Bank came. World Bank set up a specific facility. So now World Bank is co-hosting Global Preparedness Monitoring Board along with WHO. Then even UN also acted for the first time in Ebola. UN also set it up, UN response. So multiple actors are coming in, but who has the mandate to coordinate these actions? I would say it's with the WHO, and therefore it's the time also we do have this, we do understand these limitations of WHO. We do have criticisms about some of the actions of WHO, but that does not mean that to dismantle this organization or weaken this organization, but it is a time to strengthen this organization because which has the constitutional mandate to coordinate the international health.